Welcome back. In this portion of the lecture, we're going to talk about something that's specific to wound healing trials. In this case, arterial assessment in clinical trials. I'm Tom Serena again, founder and medical director of the Serena Group. You've seen my disclosures multiple times. Get to see them again. So let's look at some questions. All patients with lower extremity ulcers being screened for a clinical trial should have an objective assessment of their vascular status. True or false? All the following tests are appropriate screening for vascular status in a clinical trial except arteriography, ankle brachial index, skin perfusion pressure, pulse volume recording. All right, Edwin Smith, someone you've heard before, you're the principal investigator, you're the captain of the ship. If somebody hands you a protocol, the venous leg ulcer, diabetic foot ulcer, any break in the skin in the lower extremity, and there's no arterial assessment, you need to pipe up, you need to talk, you need to call the sponsor and say, well, there's something missing in this protocol. I don't see any assessment of the vasculature. Because if you're not assessing arterial inflow, then you really cannot assess any type of treatment whatsoever. The key principle, and one of the key principles in the conduct of clinical trials is the same way every time by everyone, everywhere. And that's really important. It's one of the things you stay in the operating room, same way every time, and try to standardize your procedures so they're consistent across your institution, across the U.S. Well, that's really important in clinical trials. It's important that we use a standardized way to assess the circulation, a standardized way to apply compression, a standardized way to debride the wounds, and that everybody agree, even though that may not be the way you always do it. Listen, for this clinical trial, when we're treating these subjects, we are going to treat them the same way every time by everyone, everywhere.